Backache and cervical pain are two common complaints with which patients come to a doctor. So today let us talk about spinal disorders. When we talk about spinal disorders, it is actually two groups of illnesses. One is disorders of the spinal column, and the second is diseases of the spinal cord and the nerves coming from the spinal cord. The spinal cord diseases we will deal with in a separate talk. So we are talking about disorders of the spinal column. The spinal column is made up of a stack of 33 vertebrae. In between the mobile vertebrae, you have a cushioning intervertebral disc. The design of this disc is ingenious. You have an outer firm covering and an inner soft gel so that it can absorb shocks. Disorders affecting the vertebral column include trauma. In trauma, you might have fractures of the vertebral body. Fractures of the vertebral body differ from fractures of long bones because the vertebral body is almost square shaped. The most common kind of fracture is an anterior wedge compression. Unless it is very significant, more than half compressed, usually surgery may not be required because stability is not compromised. A more ominous kind of compression fracture of the vertebra is a burst fracture. Here a fragment can go back and touch upon the spinal cord or nerves. The intervertebral disc is also prone to injury. The disc outer covering may rupture, the annulus fibrosus ruptures, and the inner soft nucleus pulposus can come out, compressing the nerves. There are other diseases of the spinal column. You have tumors. There are infections of which tubercular TB spine requires special mention. And then you have degenerations, that is wear and tear, discs become desiccated, osteophytes form. All of this can compromise the nerves which are passing behind the vertebral bodies. What are the symptoms of a person who has a spinal column disorder? Generally, you can classify it into three groups. You have initially sensory symptoms, paresthesia or numbness, and the second is pain. The second group of symptoms is motor symptoms. Patients develop weakness. The third group includes autonomic complaints. The bladder might dysfunction, and you can also get what we call a cauda equina syndrome. How do you evaluate a patient with a spinal column disorder? There are two kinds of imaging which can be used. One is X-rays or a CT scan. These are good for evaluating the bony anatomy. But if you want to see the nerves and you want to see the disc in detail, it is better to have an MR imaging. So once we have an MRI imaging and you have the clinical profile, you see if the clinical features correlate with the findings on the MRI. If they correlate, you are likely to have a good result when you try to correct the pathology that you are seeing. After you do an MRI, then you come to a decision. You talk to the patient, what are the options? I would say around 75% of disc degenerative disorders can be managed by just lifestyle changes. What we advise patients is that three things they should avoid. Avoid loading the spine. That is, any weight that you lift, the load is transmitted, compresses the spine. Avoid flexing the spine. When you bend forward, the disc gets pushed back impinges on the nerves. And the third is avoid impact. Don't jump and land, because then the disc gets further compressed. What you should do is walking. Walking, low impact walking, is good for the paraspinal muscles. It gives dynamic stability to the spine. With each step, the muscles are getting warmed up to keeping the spine in alignment. The second is hanging by the hands, an easy way to give traction to yourself. Find a bar of the right height, hold it, lift your feet off the ground. Your hips and your legs give traction to the spine. The olden days we used to put a belt and put a weight and keep them in bed. Serve two purposes, bed rest as well as a bit of pull. By doing hanging, you can give traction to the spine. And the third is isometric spine toning exercises. This gives additional support to the vertebral column. If lifestyle changes are not enough, and initially to tide over a period of pain, patients sometimes require medication. Medication includes analgesics. Analgesics may sometimes be even steroidal to reduce the inflammation of the nerve. And the second group is the nerve soothing agents, which modulate transmission of pain. Gabapentin, pregabalin. Then we think about the surgical options. If an MRI shows a large extruded disc or a fracture with instability, then there is no point going through lifestyle changes and medication. Surgery is the only option. In cases where surgery may not be required, you try the conservative methods. If they fail, then surgery can be considered. What is the surgery that you do? There are two aims of surgery. The first is you want to decompress the nerves, relieve the pressure on the nerves by removing a disc, by removing bone which is compressing the nerve. So decompression. The second is the spine is inherently unstable. That is the reason why the disc prolapsed. So some kind of stabilization is desirable. So that is usually done with what we call a pedicle screw construct. So stabilization and spine decompression of the nerves provides usually quite a reliable and a resilient result. Thank you.